So welcome everybody, and thanks for letting me be part of your conference. I want to start by telling you that in the suicide prevention community, the language around suicide has changed in about the last 5 to 10 years or so. And the suicide prevention community is really united around asking people to please stop saying committed suicide. Why would you think that would be? What might be wrong with committed? Yeah, it sounds like a crime, exactly. And that's exactly where the language originally came from. From when it was a crime, you commit murder, you commit a felony, right? And you committed suicide. And now the thinking is, as long as we continue to talk about suicide in that same language, right, when everything else that you commit is bad, right, it only adds to the stigma around that for people who want to seek help, for people who've attempted, and certainly for family members and friends who are left behind as survivors. So the preferred language now is died by suicide. I will tell you, many families say lost to suicide in the same way you'd say we lost my mother to cancer, we lost my father to suicide, in that same neutral, non-judgmental language. Many people actually just call out the illness that the person died from. So my sister died of bipolar disorder. My husband died of alcoholism, right? In that same vein. So I will challenge you to do that, but I promise you this is really hard. I do this every day, and it took me months to stop saying it. When you've said it that way your whole life, it's really hard to unlearn something. So, but you'll at least get to hear me model that for the next hour. So how common is suicide? Luckily, we're very lucky. It's actually a really rare event. It's so rare that you have to talk about it per 100,000 people. Like most things we say, 1 out of 10 people is left-handed, or 1 out of 100 people develop schizophrenia. A number you can wrap your head around. Well, suicide is so rare that you have to talk about it in these huge numbers. And in the United States, our rates right now are about 13.3 per 100,000. But that translates into about 44,000 people in the United States a year who die by suicide. And the biggest majority of those are veterans, right? Even though veterans make up only 13% of the population, they make up about 20% of all suicides, so the risk is much higher among that population. And we know that this is, that's just the tip of the iceberg. It doesn't count all the people who've attempted and who sought treatment after that, and all of the people who attempted and never went for treatment. I know you've probably heard people talk about, you should be worried because the suicide rate in the United States is going up. Well, here's a picture of the suicide rates in the United States over the last 100 years. And so are they going up? Well, yeah. They're incrementally going up, but it's not like this is, there's been some radical spike in suicides in the United States anytime since the early 1940s. But I do want to show you a different way to look at this. So as you can see, before that time, before we sort of got to that flat line, right, suicide rates were much higher than that. Okay, where's all my social workers in here? Okay, so what happened? What happened during the New Deal? What happened during, right, that might account for this, especially among the elderly? Yeah, way before that. Right? Social Security, right? Social Security, old age, disability, right? The safety net programs that we put in place for people who prior to that, if you were no longer able to work, right, you could easily starve to death, or if you didn't have family to take care of you, there wasn't really anything else for you. So I want to show you a different way to look at this chart This one's broken out by age. Okay, and so what you can see here is the yellow line that's down at the bottom, that's basically 5 to 14-year-olds. But the orange line that's way up at the top, that's 64 to 74-year-olds. Okay? So where those changes in our social safety nets made the biggest difference was among the deaths among the elderly. That makes sense, I think, to most people. So, a lot of people think that, if we went down here to Walmart and stopped somebody and said, at what age, what time of the year do you think we should be the most worried about suicide, right? Almost everybody says around the holidays, right? I want you to know there's absolutely zero increase in suicide around the holidays. In fact, rates of suicide actually go down. November, December, and January are our lowest months of the year. Always have been, probably always will be. We have records going back to the 1300s documenting this seasonality. The highest rates are actually getting ready to come up on us pretty soon. Late April, during May, and early June are our highest rates for suicide. And that's because the two illnesses that most predispose people to suicide, which are depression and bipolar disorder, these are seasonal illnesses, cyclical illnesses. And they have periods during the year where they're worse and periods when they're better. And you see the greatest rate of increase in that in those months. I think lots of people, if you talk to the general public, would say, women are way more emotional than men, and this is probably an issue more of an issue for women than it is for men. But we know that among the general public, men are 4 times more likely to die by suicide than women. I'm a social worker, so math doesn't do a lot for my brain. Think of it this way. 20% of the people who die by suicide are women. 20%. That means 4 times that means 80% of the people who die by suicide in the United States are boys and men. This is predominantly a male phenomenon. And the older so this is sort of the breakdown, right, between men and women. Men 4 times more likely than women, except among the elderly, and it's 6 to 1 among the elderly instead of 4. So much higher rates among elderly men. We also think a lot about we talk all the time about teenage suicide, right? We want to stop teen suicide. I'm not against that, mind you, but they get all the press when the reality is that the older you are, the greater the risk you are for suicide if you're a man. Right? And the highest rates in the United States, the highest rates of suicide in the United States are among elderly white men. Right? Men in their 70s and 80s. So I told you just a second ago that the rates in the United States are 13 per 100,000, except look at the rates for men over 85, are 51 per 100,000. Right? Much higher rates. So you can also see that this is predominantly an issue for white men, right, is the real issue. So then you have the yellow is black females, the orange is black males, right, or it's white females, the pink is black males, the blue is white males. Here's another way to look at the same thing. But it's all just to give you the visual impact that this is predominantly a problem among elderly, in the United States, among elderly white men. Yes, sir?
On your previous slide, you say urban versus rural?
This is much more of a problem in rural areas than it is in urban areas. Most people would think it's an urban problem, the anonymity of the big city and all that. But it really has more to do with 2 things. In rural areas, you have much less access to resources, medical resources, mental health resources, and much higher access to firearms. And everywhere in the country and everywhere in the world, you have higher access to firearms, you have higher gun deaths. And most gun deaths in this country are suicides. Okay, so here's sort of the take-home message that I want you to hear. What is really clear to us on both physical and psychological autopsies is that somewhere between 90 and 95% of people who die by suicide have one of about 4 or 5 severe brain illnesses. Right? If you think of that pie chart as all of the people in the United States who die by suicide in any one given year, people who have depression or depression that's part of bipolar disorder make up about 60 to 70% of those deaths. People with substance use disorders, what used to be called substance abuse or chemical dependency, account for about 25% of suicide deaths. People with schizophrenia account for about 10 to 15% of the deaths. And that last little green sliver up at the top is primarily made up of borderline personality disorder, anxiety disorders like PTSD, and anorexia. So what's important to hear is that untreated or undertreated mental illness is just as potentially fatal as heart disease or cancer or any other kind of illness. And the thing is that almost no one who dies by suicide has just one of those. Right? People have, at least 90% of people who die by suicide have at least 2 or more of those at the same time. Right? So you have severe depression and you're so miserable that you're drinking or taking medicine on top of that. When you think about suicide, I think most of the time when you hear people talk about suicide, the explanations that they give you are just way too simplistic. And I want you to hear that suicide is never, ever the result of just one thing. Right? Yes, it's true that the vast majority of people who die by suicide have one of those 4 or 5 illnesses. Right? But having that illness alone is not enough. Right? Lots of people suffer from depression or bipolar disorder or PTSD and don't kill themselves. Right? So there's more to it than that. Right? It's a very complex problem that's partly about your biology, it's partly about your environment, it's partly about your temperament, it's partly about the culture you live in, all of those things combined. Right? And the reason I have this picture of a slot machine up here is because that's the image I think about when I think about suicide. I'm sure none of y'all play the slots, but you at least have seen it on TV, you know how it works. Right? If you pull the lever and you just get one cherry or one bell, you are not a winner, right? You have to get at least 3 or 5 or 7 to win. So if you think about suicide in that same analogy, right, getting just one risk factor, even if it's a huge one, is not enough by itself. Right? Let's say you were born with the predisposition to bipolar disorder. Right? That's a huge risk factor. 1 out of 5 people with bipolar disorder die by suicide in their lifetime. Right? But that also means 4 out of 5 people don't die. So it's not just having the illness. Right? But think about it like this. If you had that illness and you currently happen to be in the middle of a terrible episode of depression as part of that illness, and you're so miserable that you're drinking or drugging on top of that, and you were a victim of physical abuse or sexual abuse as a child, and you have a family member who died by suicide and modeled that behavior, and, right, it's the ands that are the issue, right? So it's always about the cumulative effect of all of those risk factors put together. And the more risk factors you have, right, the more it increases your risk, right? That comorbidity, right, having more than one illness at the same time, more than one risk factor is what puts people at the greatest risk. So then you're basically adding those, the rates of risk together. So this is what I want you to think about, right? That it's always those multiple risk factors and the cumulative effect of that over a person's lifetime. Right? And so it helps to think about why are rates of suicide so much higher among the elderly? Right? Because they've had an entire lifetime, right, to accumulate multiple negative life events. When we think about why people with suicide, why do people want to kill themselves in the first place? And really the only answer to that question is to end the amount of pain that person is in. Okay? Most people think about that like physical pain, but really this is also about, it's both about emotional pain, psychological pain, and physical pain. Right? It's all three of those together. Because the reality is the human brain is very highly defended against suicide. Right? Your natural human instinct is to avoid pain and injury and death. Right? And your instinct is towards self-preservation. Right? It takes a lot for someone to be able to overcome that natural human instinct to keep themselves alive. And what we know is that happens when people start to the more they experience that sense of pain coupled with the sense of hopelessness that things are ever going to be able to be any better than they are right now. And they have to come together with a sense of loss of belonging, right? Alienation, isolation from other people, and a sense of feeling like a burden to other people. Those are the four things that you have to have. Right? And when you see those four things come together is when people are at the highest risk. Lucky for us, we talk about at least 70% of people give us some kind of warning ahead of time, right? And say that they're thinking about this, or this is something they've had on their mind for a long time, or they're making plans, or they make comments that would let someone else know that that's what they're thinking. And that lets us get in and do something about it. One of the problems we have in the United States, though, is the way we throw around the word depressed all the time when we don't really mean clinically depressed, right? As in, oh my God, I didn't get tickets to the Justin Bieber concert, I'm so depressed, right? And you mean disappointed or annoyed or something, you don't really mean depressed. Okay? But that when we use the word that lightly every day, it really trivializes how excruciating the suffering is for people who actually live with these illnesses. Here's one important thing to remember. Depression is not a normal part of aging. And in fact, in many, many studies, what we find is that rates of life satisfaction are highest among the young and among the old. Right? For those of us in the middle, sorry, you're in the slump there. but we know that it's less in midlife, but that for most people increases over time. Okay? So to think that people are going to become depressed just because they're old is not the reality. Okay? But our problem is that we think about, when we talk about depression, we don't recognize that depression and unhappiness are not the same thing. Right? Everyone has times in their life when they're unhappy, right? Because of something that's happened outside of yourself, right? That you're responding to, right? And we call that normal grief or bereavement, or in the old days in psychiatry, they used to call it situational depression or reactive depression, meaning you were reacting to something, some situation outside of you. But that's not what we're talking about when we say depression. We're talking about clinical depression, or what you'll hear called biochemical or biological depression, but which means feeling bad that originates from inside your body, right? From changes in your brain. Now, you can have the first one all by itself, right? You can be sad and upset about something, right, all by itself. And if you were born with the predisposition to this illness, to depression, you can have episodes of depression all by themselves, right? Not with nothing bad ever having happened to you. And in people who have that biological predisposition, some traumatic or distressing event can trigger an episode of depression. If you're young, it can trigger the onset of the very first depression in your life, the episode. It can, if you've had them before, it can trigger a relapse. If you're already in the middle of an episode, it can make the symptoms worse, or it can make the episode last longer. The point is, for most therapists and doctors, once you have the symptoms, it doesn't really matter how it got started. Like, don't spend a lot of time looking for the deep, dark secret, right? Because it doesn't matter. Once people have the symptoms of the illness, you treat it exactly the same, whether you can identify some kind of a trigger that started it or not. All right? The other thing people don't recognize that's really pertinent to working with the elderly is that depression and bipolar disorder, these are recurrent and remitting illnesses, right? They go into remission, but that means they also come back at a later time in that person's life, right, that you can't predict. Okay? If you've ever had one episode of depression in your life, there's about a 60% chance that you'll have another one. Once you've had two, there's about a 70% chance that you'll have a third one. And once you've had three or more, there's about a 90% chance that you'll have another one. And we also know that as you get older, if you have either untreated or undertreated depression or bipolar disorder, those episodes start to come closer and closer together, and each subsequent episode tends to be more severe than the previous ones. Starting to make sense to you why the elderly have higher rates of suicide? Right? Because these are tend to be progressively worsening illnesses over people's lifetime. There are three things that are influencing depression. And part of this, as we said, is your biology. That, I'm sorry, that's the hand of cards you got dealt, and there's not really much you can do about that. Part of it is your environment. It's important to realize stress in people's lives does not cause depression. But stress in people's lives can, right, trigger the onset of the illness. It can make it worse. It can make the symptoms last longer, okay, or be more severe. And the third thing is what you think, right? What you think and believe about yourself, about the world, about how things work, okay? And all three of those are working together in every person all the time. So when we talk to patients about depression, what we have to do is help them understand what these three pieces are, right? So part of it is what you were born with, but yes, part of it is related to the things that have happened to you in your life. good and bad, right? Maybe you were lucky enough to be born to warm, nurturing parents who took care of you and saw to it that you got good health care and a good education and good nutrition, right? Or maybe you were born to parents who lived in poverty and couldn't meet your needs, or where there was abuse or neglect or domestic violence, right? And either way, with those exact same genes, your outcomes are likely to be different. Right? Think of it like smoking or anything else, right? If your heart disease runs in your family and that's the genes you were dealt, well, you also know that if you smoke and don't exercise and don't get good health care and have hostile, conflicted relationships with other people and work in a high-stress job, your outcomes with those genes are likely to be worse, right, than if you don't do all those things. Okay? These illnesses are exactly the same, right? The more stress that there has been in that person's life, especially during childhood and early development, the more likely they are, right? The more severe the outcomes with that illness are likely to be for that person. So when we think about brain chemistry related to this, part of this is about the way that the nerve cells in your brain talk to each other, right? They're not like telephone wires that are connected to each other at the end, right? Brain cells come up close to each other, but they don't touch. And so the way they talk to each other is to spit out these little chemicals that travel across that gap and plug in to the other nerve to deliver the message. And one of those chemical messengers is called serotonin. And serotonin's responsible for regulating these 6 things in your body, at least, that we know of. But when serotonin levels in your brain are too low, you are not making enough of it, right? What you see is decreases in mood and decreases in appetite and decreases in sleep and increases in addictive behaviors of all kinds, impulsivity and aggression, and perception of physical pain. And people with the lowest serotonin levels are at the highest risk of depression and also at the highest suicide risk. Of course, we know it's not just brain chemistry, right? There are lots of other changes in your brain that we don't have time to talk about, but I put them all up here so that you can see that we know that there are differences in the brains of people who are depressed, right? This isn't just about what's going on in their life, right? This is changes in their biology that's influencing their ability to sleep, their ability to control their emotions, especially anger and fear, the level of stress hormones that are being activated in their system, all of those. We also know that has a consequence in your behavior. Right? So people who have depression get tired more quickly. They think more slowly. They exhibit what doctors call sickness behavior, right? Everybody knows what that is, right? How you are when you feel sick, right? No energy, no appetite, can't concentrate, can't think, right? We've all, if you've had the flu this fall, you know what that feels like, right? They have terrible problems with short-term memory and easily distracted, right? They have more problem making decisions and solving problems than they did before, right? Or than their peers, right? And they also experience lots and lots of physical pain. Most people think of depression as a psychologically painful illness, but it's actually also incredibly physically painful. People with depression have headaches and stomach aches and back aches and aches in their joints and stabbing pains in their arms and legs. Right? The problem is that look at that list, right? Can't you see how easily those things could be mistaken for some other illness or just attributed to, oh, he's just upset because he had to move to the assisted living, or he's just upset because his friend died, or, right? It's easy for people to attribute this to some medicine the person's taking or some life changes that they've experienced, when really you may be overlooking the underlying cause of that illness. Unfortunately, we also know that there are lots of medical conditions that actually cause depression. Almost any illness that affects your brain, right, that does damage to your brain, can also give you depression. Head injury is probably the most obvious one. I'm sure all of you have been reading about the National Football League players who've killed themselves as a result of the concussions they've had over their careers. And this is what they're talking about here, right? So head injuries is the most obvious one, but it's also true that any other illnesses that cause damage to your brain do the same thing, right? So strokes, Parkinson's, different kinds of dementia, right? MS, lupus, right? Those kind of things can also cause depression. We also know there are lots of medications that cause depression, right? And like the beta blockers that they give people for heart disease, some of the chemotherapies, those kind of things. So you have to watch for, right, if this person is demonstrating symptoms shortly after you've started them on some new medication, right? This may be a side effect of the meds and not some other underlying condition. So it's partly biology, but it's partly environment. And we know that in terms of suicide, there are things in people's environment that put them at greater risk, and there are things that protect them, that buffer them against the stresses of life. So we've mentioned some of the risk factors, but some of the ones that are especially pertinent are having availability of easy lethal methods. So access to firearms, access to lots of medications that would be dangerous, access to poisons, right? That's what they're talking about there. There's a reason we put barriers around the tops of tall buildings and right on across bridges, because we know that when you can eliminate easy lethal methods, that's protective, both for a whole society and on an individual level. Okay. Excessive use of alcohol, that's probably obvious to most people, right? That I grew up in Tennessee, and as they used to say, they don't call it liquid courage for no reason, right? It's something that makes people able to act on their impulses in ways that they wouldn't do otherwise. But there are things that protect people too. We know that having warm, supportive relationships with other people, being connected to other human beings, is probably one of the most important factors that you can imagine. It also matters the reason it says proximity up here is because it also matters how close that person is to you. I mean, physically close. It's nice to know that my family in Pennsylvania loves me, right? But it's not the same as having them right here, okay? The other one is religious faith. We know that religious people's having a religious or faith affiliation is highly protective for people. Doesn't matter what religion it is. It just matters that you have a sense that your life has value and worth and meaning in the universe. Right? So we talked about this one already. The reason having easy lethal means makes a difference is because in a moment of crisis or despair, if what you reach for is something like a bottle of pills, right, your chances in the United States of dying from that is about 1% to 2%. Because it takes a long time, right? It takes hours. And in hours, you have a chance to change your mind, right? And call somebody. You have a chance that someone might come in and find you and rescue you. But that's not the case with firearms. We know that somewhere between 8 and 9 out of 10 attempts with a firearm are fatal, and that means you don't get a chance to change your mind or be rescued. Right? You don't get to. There's no coming back from that. Now, of all of the environmental factors that we know of in terms of suicide risk, a history of childhood trauma is by far the greatest risk factor for suicide. And I can tell you that this is also the number one place that people fall down in their suicide risk assessments of patients. Okay? Is not asking people about their history of childhood trauma. Okay? But I can also tell you that if you ask people if they came from a history of childhood trauma, people will say no. You have to ask, when you were a child, were you ever hit, slapped, beaten, right? Did you ever witness your mother or stepmother hit or slapped or beaten? Were you ever so hungry or medically ill and no one took care of you, right? No one took you to a doctor. Asking specifically about physical abuse, sexual abuse, domestic violence, the death or abandonment of a parent, right? These are called ACEs, and I'll tell you. I want to tell you quickly about them. There are 10 ACEs. They're called Adverse Childhood Experiences, and they're all about the things that I just mentioned. They did Kaiser Permanente, the insurance company, did a huge study with originally 17,000 people that the CDC's now added another 30,000 to, looking at how many bad things happened to you when you were a child. For each one, like sexual abuse, physical abuse, witnessing domestic violence, for each one of those events, you got 1 point. Right? Not for how many times it happened, but just that it happened. Okay? What they found was the greater your ACE score, the higher the number of those events that happened to you when you were a child, the more likely you were to develop every single one of the things on this slide and about 70 more that I couldn't get on here. There's almost nothing that's not made worse by early childhood trauma and adversity. Okay? Because when those things happen to you while your brain is still growing and developing, it affects your body's immune system and makes you less able over your entire lifetime to fight off, right, for your body to fight off other illnesses, right, and other kinds of disease processes. So you're, yes, before 18, before the age of 18.
I'm thinking about young. Is there, at what age does it matter? For instance, a 6-month-old versus a 6-year-old.
So the question was, does it matter more if it's a 6-month-old or a 6-year-old? Before the age of 3 has higher consequences, but there is consequences all the way up until at least 18. Okay. Think about it this way: if you are experiencing child abuse, right, and what you're experiencing is painful and terrifying, right, and the people who are supposed to be taking care of you are the ones doing it, right? What happens is, your brain, your body goes into fight or flight response, right? Which is great if you're in a forest and there's a bear, right? The problem is, what happens if the bear comes home every night, right? And that emergency, what's supposed to be a temporary emergency response system, gets left on all the time, right? It's doing damage to your brain and your organ systems over time, right? That has a cumulative effect. Okay? So we know that that's also true for depression and suicide, right? The break point for in the studies was 5 or more. So you can see on this chart down here, right, that even if you've had 1 or 2 ACEs, right, your risk of suicide or suicide attempts is really low in your lifetime. But once you get to 5 or more, right, it's astronomical, right? Your rate, if you've had 7 or more ACEs, your risk of attempting suicide in your lifetime is 1 in 3. Right? Okay. Here's the other piece of this that I want you to think about, and that is that people, I said that, you have to overcome your brain's natural instinct towards self-preservation, right? So people have to acquire the ability to kill themselves, right? And that takes a long time, right? It takes people a long time to do that. Because to get there, you have to have 3 things. You have to know what would work, right? You have to have the capability, the knowledge of what would actually kill you. Right? And you have to have had enough experiences in your life that helped you get used to pain and fear so that you gradually realize, this might be scary or this might hurt some, but I can do it, right? I can live through it. It'll be okay, right? And some of those things we just already talked about, right? What are the kinds of things that make you get used to pain and fear, right? This is not fearlessness, right? This is courage that over time you've practiced long enough that you've gotten really good at it. Even something that started out really scary. Okay? So we talked about some of these, right? Having been a victim of child abuse, a victim of domestic violence, right? People who've attempted suicide in the past, right? All of those are let you get used to pain and fear and become habituated to it, inured to it, right? You learned that you could live through it and come out the other side, right? Many people who die by suicide practice ahead of time, right? They go and stand on the edge of the bridge, right, and look over to see what it's going to be like and imagine that, right? They've thought this through and they've gone on the internet and looked up what it's going to take, right? They didn't just do this, instantly, okay? But there's lots of other things, right, that people do over a lifetime, right, that are the kinds of events that help people become inured, right, habituated to pain and fear and have learned to tolerate it, right? Here's the thing. So those people have developed capacity, right? The ability to stare down fear and death. Right? So lots of people are capable, right? Lots of people have been in the military or gone hunting. They know how to handle guns. They're not afraid of them, right? That's capacity, okay? So lots of people have capacity. But the thing is, those people don't want to die. Right? And lots of people in the world want to die, but they haven't developed the capacity. The people we're worried about is the people in the middle, right, who have both the desire and the capacity. Okay? The thing is that capacity is stable. You can't suck knowledge out of people's heads, right? If you're a doctor, you know what's going to work, right? If you're a nurse, you know how much of different medicines it would take to kill you. Right? I can't take that away from you. But desire waxes and wanes. Right? Desire fluctuates. So we can't affect capacity, but we can affect desire. And the 2 things that make people want to die, and all the research is really clear on this, is feeling like and it's in your slides, is feeling like you no longer belong, right? That you're not part of a family or a group or a tribe, right? And feeling like you have become a burden to other people, especially the people that you care the most about. When people leave suicide notes, and very few people do, but when they do, they often reflect the fact that what the person thinks they're doing is altruistic. Right? They see themselves as a burden to other people, and that their death is going to be worth more to the people they love than their continued existence. Okay. So thinking back to that, right, to that slide I showed you earlier, does this sense of burdensomeness and lack of self-efficacy, right, also helps to make sense out of that. So when you think about what the risk factors are that we identified, right, how does that model explain, why someone who's had previous attempts is at higher risk than somebody who's never attempted? Because they've developed capacity, right? They've learned that they, yes, it hurt, but I was able to do it, right? Why someone who has recently lost their spouse to death or divorce, why would it put them at greater risk? Right, being part of a group, lack of belonging, right? So when you think about all of these things, all the risk factors that we talk about for suicide, they're really related to these two concepts of capacity and burdensomeness and lack of belonging, right? So why does losing your job, right? It's partly about burdensomeness, about not financially contributing, but where do most people get their sense of purpose and value and meaning and worth? And where do most people socialize the most, right? With the people that you, right, with the relationships that you have with the people you work with. Most of us spend more time with the people we work with than our own families, right? So all of these things, right, are about, like, substance abuse. Yes, it's about making people more impulsive when they're intoxicated, but what does having a substance use disorder do to your relationships with other people? Right? Yes, you alienate everyone who ever cared about you, right? What does it do to your ability to keep a job, right? So you can see that this is all interconnected, right? Having chronic medical problems, right? Especially something that there's no good prognosis for, right? Having been in the military, right? All of those things are things that when we think about them and you think about this model for how they affect your sense of being a burden and your sense of purpose and worth and your sense of belonging. Right? So think about it like this, right? To have a fire, you got to have three things, right? Oxygen and heat and fuel. And if you take one away, you can't have a fire. Well, I think about suicide the same way. For someone to die by suicide, they have to have the capability of doing it. They have to feel like they don't belong, and they have to feel like a burden. You can't influence capability, but you can influence belonging and burdensomeness. Right? Believe it or not, it's so much more simple than you think. In one study that they did, they took people in a nursing home and they randomly assigned a small number of people to look after the house plants, right? To water them and pull the dead leaves off of them and make sure they got enough sunshine and everything. And those people lived longer and did better than the people who didn't, right? So a sense of worth and meaning and value, right, doesn't have to be a huge big thing. It can be little things that connect people to other people and that connect people to a sense of meaning, which is where the thoughts and beliefs come in, right? That we used to think your feelings came first and then you tried to figure out why you feel that way. And we know now it's the opposite, that when you face some situation, you have some automatic thought about that situation, and then you feel something based on what you thought. And the classic example of this is you go to the mailbox and the mailbox is empty, right? And so you might say to yourself, ha, no bills. And then you'd be doing a little happy dance, right? Or you might say to yourself, oh, it was my birthday and no one remembered and no one cares about me, and then you'd be sad. Okay? But the point is that the situation was identical. The mailbox was empty. And the only difference is the meaning that you gave to the empty mailbox. So our therapies for both anxiety and depression are based around what we know about this, that if I can change how you think about this situation, it's going to change how you feel about that situation. Okay? And a lot of the brain illnesses that we know predispose people to suicide impair people's thinking processes. They impair their judgment. But it's also really easy for the people around them to listen for language like this, right? I'm just not good enough. Nobody loves me, right? I'll never be able to do this. Nothing's going to ever be any better, right? I'm no good. It's easy for people to listen to that, for that language. And that is someone who's either already depressed or well on their way to talking themselves into it. So what's important is all three of these things in every person are working together. Right? Your brain chemistry messes up how you think, but how you think changes how much stress you feel. And how much stress you feel changes your body chemistry. So you can't treat just one. Right? It's not enough just to throw medicine at it and leave this person in a situation where they're miserable. Right? If you're a victim of domestic violence and I just give you antidepressants, that is not going to, you're not going to get any better. Okay? So it's reducing stress in that person's life in any possible way. It's getting them therapy to help them change how they interpret the world, and it's addressing the changes in brain chemistry, right? So we use medicine and all kinds of treatments to change the way the person's brain functions. We use what's called cognitive behavioral therapy to change the negative thought patterns that people get themselves stuck in. And we do everything we can to increase people's connectedness to other people, their sense of value and purpose, their reducing stress in their life in any way we can, and increasing protective factors in any way we can. Okay? So I've given you some examples of some of these in your notes, in your handouts, but anything that you can do to reduce stress in that person's life and to increase the protective factors in that person's life are the kinds of things that are going to reduce the risk of suicide for that particular person. Of course, the groups in the country that we're the most worried about now are our elderly veterans. So our veterans of World War II, Korea, and Vietnam, because they are now in that age group that are at the greatest risk. And we know that that's the group that's at highest risk at this point. If for those of you who work in residential settings, there are 5 risk factors that are the most important, and I would ask you to pay attention to the fact that there's a lot of things in people's lives you can't do anything about, right, that you can't change. So you have to look for the risk factors that you can do something about, right? And insomnia and anxiety are two of the most dangerous risk factors for suicide, and they are also easily modifiable. Right? You can give people medications to help them sleep, and you can give people medications to temporarily reduce anxiety, and both of those greatly reduce people's immediate risk. The problem is that of all the things that we said create risk of suicide for anybody, right? Lack of social connectedness, physical illnesses, poor sleep, right? We also know that as people get older, right, that we know those problems increase for most people. Right? People become more isolated. Right? They have more difficulty sleeping. Right? And that, I think with our recognition that that happens, right, we have to think about this in settings where we work with people who are aging. In your agencies, I hope none of you are still doing this, but there used to be a model in most mental health and medical facilities where they basically said to people, do you promise that if I don't put you in the hospital, do you promise that you won't kill yourself till tomorrow when I can get you an appointment with a doctor? It turns out we now have two huge national studies that prove that it doesn't work. It's a risk management device. Lots of places use it, but really it does not put the patients at any less risk. And I also urge you to screen everybody that you work with for veteran status. Don't get stuck in the caricatures, the stereotypes that to be a vet you have to be the young buff guy working out, or that you're the old hippie, right? You need to ask even grandmothers if they have served in the military before. I just want to say a quick word about what people sometimes call rational suicide, meaning that this is something the person has thought about in advance and not impulsive suicide. We know that this is less than a fraction of 1% of the people who actually die by suicide in the United States. This is not typical for anyone, including the elderly. And there are national criteria for defining rational suicide, and I'm going to leave those to you to look at your leisure. But I think when we think about the fact that about 40% of people will not have a short, discrete period of dying, right? That for most people, it's a really long, protracted period of months or years of chronic illness and progressive deterioration, that we have to start thinking about these kinds of issues. When you think about aging and death, that's on a continuum for most people, right? And we need to think about not just giving people more time, but thinking about how that time will be spent, right? The more time that they have, and making sure that social connectedness is a piece of that. Because believe it or not, social connectedness is more important than to your health than smoking or not smoking, right? Than exercise, than almost anything else that you can do. Having warm, supportive relationships with other people is the most important protective factor that you can have. It's not just relationships, though. Remember that if you are in a relationship that is full of anger, hostility, discord, or just increases your sense of burdensomeness, right? that's not a protective factor. It's relationships that, that make that person feel cared about and valued. Thank you all for having me.